Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team. This week, we're discussing ARISE fluids, a thoughtful new addition to the sepsis resuscitation conversation. Less fluid and earlier vasopressors changed how care was delivered and was associated with less pulmonary edema, but did not improve days alive and out of the hospital. For more context, listeners may also enjoy revisiting PRISM Rounds, episode 35, on choosing fluids in sepsis, and episode 40 on the PRoMPT BOLUS study.
You are in the emergency department. It's late. The monitors are chiming in that relentless high-pitched rhythm, and you have an adult patient right in front of you with a suspected infection.
Yeah, and they usually look terrible at this point.
Oh, absolutely. Mottled skin, altered mental status, just the classic presentation of someone who is actively crashing.
Right.
And they remain hypertensive after receiving about 1 liter of crystalloid fluid. Their lactate is elevated, and you've already started the broad-spectrum antibiotics.
Which is standard, yeah.
Right. So the critical care team is staying at the bedside, and you're all just staring at the numbers on the screen, deciding on the next move. Do we hang another liter of fluid, or do we start early norepinephrine?
Yeah, I mean, it is the classic bedside crossroads, right?
It really is.
And it's a decision that clinicians make, multiple times a day in emergency departments and intensive care units all around the world.
Oh, for sure.
Yet it somehow remains one of the most fiercely debated topics in acute care medicine. We're looking at a patient in the early, highly dynamic phase of septic shock.
Right.
And at this exact moment, every single intervention we choose carries both profound potential benefit and, frankly, devastating potential harm.
Okay, let's unpack this. We're going to thoroughly examine this trial, which is a rigorous, incredibly ambitious study designed to bring some much-needed clarity to this exact bedside scenario.
It really is an impressive piece of work.
Welcome to PRISM Rounds, Season 1, Episode 46. Our mission today is to dive deep into the ARISE fluids trial, which was published in the New England Journal of Medicine.
It's such a vital trial to discuss.
So the core question driving the trial and our entire deep dive today is this. In adults with early emergency department septic shock after receiving initial fluid, does a strategy of restricted fluid plus early vasopressors improve days alive and out of the hospital at 90 days, compared with a strategy of greater fluid plus later vasopressors?
That is the pivotal question.
Yeah.
And, to truly appreciate why the trial has spent years of their lives asking it, we have to look at the existing clinical uncertainty.
The uncertainty that necessitated the ARISE fluids trial in the first place, right?
Exactly. I mean, if you look at the current guidelines, specifically the Surviving Sepsis Campaign guidelines, they provide what's classified as a weak recommendation.
Right. A weak recommendation for administering at least 30 milliliters per kilogram of body weight of intravenous fluids within the first 3 hours.
Yeah, specifically within 3 hours of recognizing sepsis-induced hypotension. And the European Society of Intensive Care Medicine guidelines make a very similar recommendation.
I'm really glad you brought up the guidelines right away because if you're listening to this and thinking, wait, I have to give 30 milliliters per kilogram or my hospital fails a quality metric, well, you aren't alone.
No, not at all. It's a huge pressure.
We often see that 30 milliliters per kilogram rule treated as an absolute reflex, like a hard and fast mandate rather than a nuanced recommendation.
Yeah, people just order it without thinking sometimes.
So how does the clinical community actually balance that intense pressure for guideline compliance with the individual, highly complex physiology of the patient right in front of them?
Well, that's exactly where the tension lies at the bedside. And honestly, it's where a lot of the anxiety in modern emergency medicine comes from.
Totally.
On one hand, you have a very solid historical and physiological rationale for giving fluids. When sepsis hits, the body mounts this massive inflammatory response.
Right, a huge cascade.
Yeah, and this causes profound vasodilation, so the blood vessels widen, and something called capillary leak.
Which is the real killer.
It is. The normally tight junctions between the cells lining your blood vessels just pull apart. So the intravascular space expands, and simultaneously, the fluid that's supposed to be in your blood vessels shifts out into the surrounding tissues.
Right, leading to a severe relative hypovolemia. There just isn't enough fluid in the pipes to maintain pressure. The pump is working, but there's nothing to pump.
Exactly. So the clinician's immediate vital goal is to restore perfusion to the organs. If the brain, kidneys, and liver don't get oxygen, they die.
We have to reverse the shock state.
Right, and traditionally, the way we do that is by administering large volumes of intravenous fluid. The idea is just to increase venous return to the heart, so the heart has something to pump out.
But, I mean, pouring fluid into a leaky system has a physiological ceiling, and increasingly we're realizing it has a massive recognized cost.
Oh, absolutely. The cost is huge.
We've relied heavily on metaphors like, filling the tank and squeezing the tank for decades in medicine. I really think it's time we update that.
I agree. The tank metaphor is a bit outdated.
Instead of a simple tank, imagine the septic vascular system as a municipal water grid. But a catastrophic systemic infection has suddenly turned all the solid steel pipes into porous soaker hoses.
Oh, I like that analogy.
Right. If the pressure drops, the old school reflex is just to pump more and more water from the reservoir into the grid.
Right.
But because the pipes are now soaker hoses, that extra water doesn't necessarily reach the vital infrastructure, like the organs.
It just leaks out everywhere.
Exactly. It just floods the city streets. Pumping more fluid from the reservoir just drowns the surrounding neighborhoods.
That is a much more accurate physiological picture. There's a growing, robust awareness of the potential harms of excess fluid administration.
Yeah.
When we give liters upon liters of crystalloid like normal saline or lactated ringers, it absolutely does not all stay in the intravascular space.
Especially not in these patients.
Right, especially in a septic patient whose endothelial glycocalyx, that protective Teflon-like coating inside the blood vessels, has been completely shredded by inflammation.
Yeah, it's just gone.
So the fluid extravasates. It just leaks out into the interstitial tissues.
And the consequences of that tissue flooding are catastrophic.
They really are.
Yeah.
This leads to profound fluid overload, which manifests most dangerously as pulmonary edema.
Right, the fluid fills the delicate air sacs in the lungs, severely impairing gas exchange.
But it's not just the lungs either. We see severe organ congestion everywhere.
Yeah, the kidneys take a massive hit.
Exactly. We see edematous, swollen kidneys, where the swelling literally chokes off the kidney's own blood supply because it's encased in a rigid capsule.
Wow, yeah.
And we see congested, failing livers and swollen gut walls that lose their barrier function, which can actually feed more bacteria into the bloodstream.
It's in a vicious cycle.
It is. All of this exacerbates multi-organ failure and prolongs the patient's recovery.
Yeah.
So the clinician at the bedside is trapped.
Yeah.
They're caught between the urgent, immediate need to restore blood pressure and the looming, insidious threat of drowning the patient's tissues from the inside out.
Which brings us perfectly to the alternative strategy, right? The other side of this trial's coin.
Exactly.
If we limit the fluid to avoid that tissue congestion and instead use early vasopressors to increase the vascular tone, essentially narrowing those soaker hoses temporarily to keep the water pressure high enough to reach the critical infrastructure,
Right.
can we achieve the exact same restoration of vital organ perfusion without the downstream harms of fluid overload? That's the clinical equipoise here.
That's the great unknown. And neither the Surviving Sepsis campaign nor the European guidelines make specific, strong recommendations regarding the exact timing of vasopressor initiation.
Because the high-quality randomized evidence simply hasn't been there to back it up.
Furthermore, there's a massive cultural and operational hurdle. Historically, vasopressors are almost exclusively administered in the intensive care unit.
Right, ICU only.
Yeah. Using these potent agents earlier, particularly down in the emergency department, to actively support a restricted fluid strategy represents a seismic operational shift for many hospitals.
For sure. I mean, it might increase the demand for critical care beds or require specialized nursing protocols and much closer cardiac monitoring.
And when hospital resources are constrained, which they almost always are, this operational burden could actually contribute to inequities in care.
That's a really good point.
This lack of definitive evidence to guide early resuscitation contributes to massive, sometimes bewildering practice variation.
It's the Wild West out there.
It really is. You can walk into one emergency department on a Tuesday and see a patient receive 4 liters of fluid before a doctor even considers ordering a pressor.
Yeah.
And then walk into a different hospital across town on Wednesday, where a peripheral norepinephrine infusion is started right after the very first liter.
So to test whether less fluid and earlier pressors could solve this dilemma and actually standardize our approach, the investigators couldn't just do a small chart review.
No, not at all.
They needed a massive, rigorous framework. How exactly did they set this trial up?
Well, they designed the ARISE Fluids trial as an investigator-initiated, multi-center, open-label randomized trial.
And the scale of this is impressive.
Yes, it was conducted across 51 different sites in 3 countries, Australia, New Zealand, and another international footprint, making it a highly pragmatic, real-world, and internationally relevant study.
Right. It wasn't just done in one hyper-specialized academic ivory tower.
Exactly. The trial was meticulously designed by a specialized management committee and formally endorsed by major clinical trials networks in both intensive care and emergency medicine.
Okay, I want to focus heavily on the patient population right now, because in critical care trials, and specifically in sepsis trials, the inclusion criteria are absolutely everything.
They really are. They make or break the study.
They paint the precise picture of the patient we are treating. If you don't know who is in the trial, the results are essentially meaningless.
True.
So they enrolled adult patients who had a clinically suspected infection. But the hemodynamic criteria, the vital signs, are where it gets highly specific.
Right.
Patients had to have a systolic blood pressure of less than 90 millimeters of mercury, or a mean arterial pressure of less than 65 millimeters of mercury, specifically despite already receiving at least 1,000 milliliters of intravenous fluid.
I want to pause on that 1,000 milliliters requirement, actually.
Yeah, go ahead.
That fluid could include the initial boluses given in the back of the ambulance by paramedics before the patient even rolled through the hospital doors.
Oh, wow. Right.
So by definition, these patients are already fluid resuscitated to a degree.
Yeah.
The tank has received its initial fill, but they remain persistently hypotensive. They are still in shock.
And in addition to those blood pressure criteria, the patients had to have a confirmed blood lactate level greater than 2.0 millimoles per liter.
Yes.
Let's quickly remind everyone why that lactate number is so crucial. A lactate over 2.0 millimoles per liter isn't just a random lab value.
No, it's a very big deal.
It's a critical systemic marker of profound cellular stress and hypoperfusion. It tells us that the cells are starving for oxygen and have switched to anaerobic metabolism.
Right.
Or that the body is under such massive sympathetic stress that epinephrine is driving aerobic glycolysis into overdrive. Either way, it means the patient's physiology is screaming for help.
Precisely. It proves the shock is real at the tissue level, not just a transient drop in blood pressure.
Yeah.
And lastly, for inclusion, they had to have already begun receiving treatment with an intravenous antimicrobial agent.
So these are definitely not the walkie-talkie patients who just have a mild urinary tract infection and a slightly soft blood pressure because they're a little dehydrated.
Definitely not.
These patients meet the rigorous Sepsis 3 consensus criteria for septic shock. They are actively infected. They are persistently hypotensive despite a substantial initial fluid challenge.
Yeah.
Their cells are crying out in distress as evidenced by the elevated lactate, and their definitive treatment, the antibiotics, is already underway.
Right.
But in trials like this, the exclusions are often just as revealing about who the researchers are truly targeting.
The key exclusions are vital for interpreting these results later.
Yeah.
Patients were excluded if they had already received more than 2,000 milliliters of intravenous fluid before screening.
Okay, so a hard cap on prior fluids.
Exactly. They were also excluded if more than 6 hours had elapsed since their presentation to the emergency department.
Wow, that's a tight window.
It is. Other standard exclusions included barriers to the intervention, such as pre-existing care limitations or do not resuscitate orders, a need for immediate life-saving surgery, or if the treating clinician determined the trial protocols were simply unsuitable for the specific patient's physiology.
Give me an example of that last one.
Sure. For instance, if a patient had profound, known, congestive heart failure, where pushing liberal fluids would be obviously immediately contraindicated and dangerous.
Right, that makes total sense. So by strictly capping that pre-enrollment fluid at 2,000 milliliters and aggressively enforcing that 6-hour time limit from emergency department presentation, they are capturing an incredibly specific, narrow, and critical window.
They are capturing patients early in their shock state, right at the absolute fulcrum of the resuscitation phase.
The golden hour.
Exactly. This is the golden hour. This is before they are fully, massively resuscitated by standard care,
Right.
and most importantly, before they are heavily overloaded with fluid. This early window is arguably the only place where our resuscitation interventions have a profound trajectory-altering impact. Think about it.
Yeah.
If you wait until a patient has already received 4 or 5 liters of fluid over 12 hours on the ward to finally randomize them into a fluid-restrictive strategy, the horse has already left the barn.
Oh, completely.
The massive damage to the endothelial glycocalyx and the subsequent fluid shifting into the lungs and kidneys has already occurred. You can't unring that bell.
Yeah, the damage is done.
By catching them early, under 6 hours and under 2 liters, Arise Fluids is testing the true, unadulterated impact of the initial resuscitation strategy itself.
And looking at the baseline characteristics of the people they successfully enrolled, a median Apache 2 score of about 18, and a baseline lactate of about 3.2, 3.3 millimoles per liter across both groups means these patients were definitively profoundly sick.
Oh, incredibly sick.
The Apache 2 score is a very well-validated, complex measure of disease severity and mortality risk that factors in age, vital signs, and labs. A score of 18 is substantial.
Right, it predicts a significant risk of death.
These patients represent true severe septic shock.
They really do. They also had a median modified SOFA score of 4.
Oh.
Yeah, the sequential organ failure assessment score evaluates things like respiratory function, platelets, liver enzymes, and kidney function.
Yeah.
A score of 4 further confirms they had significant multi-system organ dysfunction right at the starting line. It's a very well-selected, highly relevant cohort that perfectly mirrors the sickest, most complicated patients we see rolling into the resuscitation bays every single day.
Okay, so now that we know exactly who was in the trial, what exactly did the protocol ask the frontline clinicians to do with them? Let's break down the one-to-one randomization.
Sounds good.
And I want to clarify this immediately, right out of the gate, to dispel any myths that circulate on social media when these trials come out.
Always a good idea.
This is not a no fluids at all versus fluids trial. We are talking about less fluid plus earlier pressors versus more fluid plus later pressors.
That's a crucial distinction and a very common misconception. We are comparing strategies of timing and volume, not absolutes.
Right.
Let's look at the vasopressor group, which represents the restricted fluid strategy. Once the patient was randomized into this arm, routine intravenous resuscitation fluids were stopped immediately. A hard stop.
Wow.
Yeah. Vasopressor therapy, typically a norepinephrine infusion, was commenced right away to attain the target mean arterial pressure, which was usually set around 65 millimeters of mercury, according to the clinician's preference.
Okay.
Furthermore, standard maintenance fluids, those slow, continuous drips of saline we often leave running, were actively discouraged by the protocol.
But they weren't left completely bone dry if their physiology rapidly demanded volume, right? Because I can hear the seasoned clinicians listening to this getting nervous at the thought of totally withholding fluid from a crashing patient.
Right. Correct. They weren't ignored if they deteriorated. The protocol had safety valves.
Okay, good.
It allowed for small 250 milliliter fluid boluses, but only for highly specific, protocolized indications.
So no reflex boluses.
Exactly. A clinician couldn't just hang a bag of fluid because the blood pressure was a little soft or because they felt like it.
Right.
They could only give that small 250 milliliter bolus for refractory hypotension, persistent signs of hypoperfusion, like a delayed capillary refill time, a lactate level greater than 4 millimoles per liter, or a lactate that was continuing to rise despite 2 hours of resuscitation.
Got it.
They could also give it for persistent severe tachycardia, or oliguria, which they strictly defined as a urine output of less than 0.5 milliliters per kilogram of body weight per hour for 2 consecutive hours.
All right.
So fluid was permitted, but it was tightly, rigidly restricted, and heavily symptom-triggered.
Contrast that approach with the fluids group, the higher volume arm. This arm essentially mimics usual guideline-directed care.
Yes, exactly.
In this group, patients could receive up to 1,000 milliliters of intravenous fluid right within the first hour after randomization if hypotension or evidence of hypoperfusion persisted.
Yeah.
Following that initial aggressive hour, further 500 milliliter fluid boluses could be administered continuously as needed for ongoing hypotension or hypoperfusion.
Right. Much more liberal.
In fact, the protocol actually recommended administering fluid up to that 30 milliliters per kilogram guideline target within the first 3 hours, unless it became overtly contraindicated by something like flash pulmonary edema.
And in this fluids first group, vasopressors were held back. They were only started later.
Right.
Specifically, they were initiated if the target mean arterial pressure was not achieved, and the treating clinician judged that the patient's intravascular volume was finally restored or that the patient was simply no longer fluid responsive. In other words, you try your hardest to fill the tank first. You push the fluids. And only when you are completely convinced the tank is full or that adding more fluid to the system won't improve the hemodynamics do you finally reach for the vasopressors to squeeze the vessels.
You know, the physiological rationale between these two arms is fascinating because it's essentially testing two completely different, somewhat opposed schools of thought in critical care medicine.
Yes, the fluids group represents standard liberal resuscitation. It assumes that the primary overriding derangement in early sepsis is absolute and relative hypovolemia, and the primary most effective treatment is rapid volume expansion.
Right.
The vasopressor group, on the other hand, relies on increasing vascular tone early, and the pharmacology of this is brilliant.
Tell me more.
By initiating an alpha-adrenergic agent like norepinephrine early, you aren't just raising the blood pressure number on the monitor, you actively increase venous return by constricting the venous capacitance vessels.
Yeah.
The venous system holds about 70% of our total blood volume. By squeezing those veins, you effectively mobilize the patient's own unstressed venous volume, shifting it into the stressed volume that circulates and perfuses.
That's amazing.
Yeah, you are giving the patient an autotransfusion of their own blood while simultaneously increasing arterial tone to maintain perfusion pressure, all while intentionally preventing the accumulation of exogenous artificial fluid in the tissues.
Hold on, I've got to push back here on the operational reality of this. Starting vasopressors immediately in the emergency department, within minutes of a decision, often means using peripheral intravenous lines.
Oh yeah, this is a big point.
For decades, there has been a massive, deeply ingrained hesitation, a real fear, honestly, to run vasoactive medications through peripheral lines due to the risk of extravasation.
Yes, the fear of necrosis.
Right. The fear is the IV slips out of the vein, the norepinephrine leaks into the surrounding arm tissue, causes profound local vasoconstriction, and you end up with local tissue ischemia and a necrotic arm. Did they actually use peripheral lines here, or did they delay care waiting for central lines?
What's fascinating here is that they absolutely did use peripheral lines, and it highlights a major, incredibly important shift in modern clinical practice.
Really?
Yeah, the protocol explicitly allowed it, and the data shows that peripheral vasopressors were not just used, they were extremely common and highly feasible.
Wow.
Over 70% of the patients in the early vasopressor group received their continuous infusion through a peripheral venous catheter in the first 24 hours.
That is wild.
And it wasn't just for a few minutes. The median duration of peripheral vasopressor administration was over 6 hours.
Wow. 6 hours of peripheral pressors.
Yes. This definitively demonstrates that in a monitored critical care area, like a modern ED resuscitation bay, early peripheral vasopressors can be deployed safely without waiting for a physician to sterilely prep, drape, and place a large central venous catheter in the internal jugular or subclavian vein.
Which takes forever.
Right. Waiting for a central line is a massive operational hurdle that historically delayed pressor initiation by hours. This trial proves you don't have to wait.
That is a huge takeaway just from the methodology alone. Okay, so we have a meticulously designed protocol, but a protocol on paper is only as good as its execution at the chaotic bedside.
Oh, absolutely.
You're asking busy, stressed emergency department clinicians who have had fluids first drummed into their heads since medical school to potentially act against their deeply ingrained habits.
That's a huge ask.
Did the treating clinicians actually achieve real clinical separation between the two groups? Because if both groups just got a bunch of fluid anyway, the trial is a wash.
They achieve remarkable, undeniable separation.
Excellent.
The trial randomized 1,000 patients with a final intention to treat population of 963 patients. We're looking closely at the intervention actually delivered over the first critical 24 hours.
Let's hear the numbers.
In the early vasopressor group, the restricted group, the median fluid volume administered over those 24 hours was 1,140 milliliters. In the fluids first group, the liberal group, it was 2,248 milliliters.
That is a clear, definitive difference of about 1.1 liters between the two strategies in the first 24 hours.
Yeah, it's substantial.
And looking even closer at the first 6 hours, which is arguably the most intensive, chaotic resuscitation window where habits are hardest to break, the early vasopressor group received a median of just 500 milliliters compared to 1,500 milliliters in the fluids group. That early restraint by the treating physicians is striking.
It really is a triumph of trial execution, and the data on vasopressor timing is equally distinct.
What was the breakdown there?
Vasopressors were ultimately used in 86.5% of the restricted fluid group, compared to 67.6% of the liberal fluid group.
Right.
But the most critical metric here isn't just if they got them, it's the timing. The median time to vasopressor initiation was drastically different. It was 0.4 hours, that's just 24 minutes in the restricted group, versus 1.4 hours in the fluids group.
Here's where it gets really interesting. A 1.1 liter difference over 24 hours might not sound like a massive ocean of fluid to a layperson.
No, it might not.
But clinically, in a septic patient with totally disrupted endothelial integrity, that extra liter isn't staying in the blood vessels.
Definitely not.
It is entirely capable of third spacing into the lungs, worsening oxygenation, or into the bowel, causing an ileus. Furthermore, a 1-hour difference in starting a vasopressor infusion might seem trivial on a long shift, but in a state of profound shock, an hour is a lifetime at the cellular level.
Absolutely.
This data proves that protocolized restraint actually works in the heat of the emergency department. The trialists managed to change deeply ingrained clinician behavior successfully over that first critical day of care. The two groups experienced distinctly, fundamentally different hemodynamic management strategies.
The adherence to the rules was exceptionally high. Less than 2% of the vasopressor group received a fluid bolus without a strict algorithm-guided indication.
That's amazing.
The investigators successfully created two very different treatment realities. They executed the clinical trial practically perfectly in a highly chaotic environment.
So we've established that the trial worked mechanically. The intervention was delivered exactly as designed. But did this impressive difference in management actually translate to a meaningful difference in outcomes for the patient? Let's look at the primary result. The primary outcome of the ARISE Fluids trial was days alive and out of the hospital through day 90.
It's important to explain why modern critical care trials choose this specific metric over simple mortality.
Yeah, please do.
Days alive and out of the hospital is a fantastic, highly patient-centered composite outcome. It captures not just whether a patient survived to a certain date, which is obviously paramount, but it also captures the severe morbidity and the prolonged burden of their recovery.
Let's do the math on how it works.
Sure. If a patient tragically dies on day 2, they were assigned 0 days alive and out of the hospital.
Right.
If a patient survives the infection but spends 80 days languishing in the intensive care unit on a ventilator and then on a hospital ward recovering from dialysis-dependent kidney failure and muscle wasting, they only get 10 days alive and out of the hospital.
Which reflects a really rough course.
Exactly. But if they bounce back quickly and go home on day 10, they get 80 days. It beautifully captures the true trajectory of recovery that matters to a patient.
And the result of the trial, based on this incredible metric, it was completely unequivocally neutral.
Yep.
The median number of days alive and out of the hospital at day 90 was exactly 76 days in the early vasopressor group and exactly 76 days in the fluids first group. Identical.
The difference was 0.0 days, with a 95% confidence interval ranging from -2.7 to +2.7 days. P equals 1.00. You literally cannot get a more neutral statistical result than a P equals 1.00.
We need to deeply unpack the psychological and clinical significance of a neutral trial here. Very often, in medicine and in the media, there's a strong tendency to view a neutral trial as a total failure.
Yeah, like it was a waste of time.
Right, as if we wasted time because we didn't find the magical silver bullet. But that's the entirely wrong way to look at it. We must emphasize this strongly. Completely different. Opposing resuscitation strategies were successfully achieved at the bedside, but the main patient-centered outcome was completely unchanged.
Wow.
This means that at a massive population level, neither strategy is inherently superior for overall recovery time and survival to 90 days. Squeezing the tank early didn't miraculously speed up recovery and get them home faster, and filling the tank more liberally didn't systematically condemn the patients to prolonged catastrophic hospitalizations. This is exactly what I wanted to talk about. If the primary outcome is exactly the same, does this actually give us the ultimate freedom to tailor the choice to the complex patient right in front of us, rather than adhering to a rigid, one-size-fits-all fluid mandate?
Yes.
If the 30 milliliters per kilogram rule doesn't guarantee a better outcome than a highly restricted approach, the clinician is finally empowered to use their brain, their clinical judgment, and bedside tools based on the specific phenotype of the shock they're looking at.
If we connect this to the bigger picture,
Yeah.
it absolutely does give us that freedom. It effectively dismantles the dogmatic idea that there is a single, infallible pathway for every single patient who walks into the sepsis.
Exactly.
It shifts the entire paradigm from blind algorithmic obedience back to intelligent physiologic assessment.
But wait, I have to play devil's advocate here. If the primary outcome, the destination, was neutral, we still have to aggressively interrogate the safety profile of the journey. Just because the number of days alive and out of the hospital at day 90 was the same doesn't mean the journey over those 3 months was identical or equally safe. Did aggressively squeezing the vessels early cause stealthy ischemic damage, or did filling the tank cause patients to temporarily drown in their own fluids? Let's dive deep into the secondary outcomes and the safety data.
Let's start with mortality, which is always the most definitive secondary outcome we look for. 90-day all-cause mortality was 16.4% in the early vasopressor group versus 14.4% in the fluids first group.
Okay.
This yielded a relative risk of 1.14 with a 95% confidence interval of 0.85 to 1.54.
We must be very, very precise with our language here. That 2% absolute mortality difference is not statistically significant. The confidence interval crosses the number 1, ranging from 0.85 to 1.54.
Right.
That means we cannot say with any statistical certainty whatsoever that one strategy is more lethal than the other. It could entirely be due to random chance.
Absolutely correct. We must actively avoid implying any statistically significant harm or increased death rate from early vasopressors based on this specific mortality data.
Thank you.
The hazard ratio for death by day 90 was also statistically similar across both groups. Furthermore, when we look at days alive and free of organ support at day 28, meaning the number of days a patient was breathing without needing mechanical ventilation on a breathing machine, days without needing continuous renal replacement therapy for failing kidneys, or days without needing ongoing vasopressor infusions, the results were broadly reassuringly similar between the two treatment arms.
Okay, good to know.
The restrictive strategy of clamping down the vessels early did not induce severe ischemic acute kidney injury requiring dialysis, nor did it result in a massive, terrifying increase in limb ischemia or other organ failures driven by early vasoconstriction.
That is deeply reassuring. But there is one glaring safety finding that we need to examine very closely, because it's exactly what the physiologist warned us about, and that is the rate of pulmonary edema.
Yes, this is the critical defining safety finding in the trial. Pulmonary edema fluid backing up into the lungs was significantly lower in the group that received early vasopressors and restricted fluids.
Give me the numbers on that.
It occurred in just 0.6% of the vasopressor group compared to 5.0% in the fluids first group.
That's a big jump.
It is. That is a relative risk of 0.12 with a highly significant p-value of less than 0.001. From a pure physiological standpoint, this makes complete sense.
Yeah.
If you give a patient who already has massive inflammatory capillary leak an extra 1.1 liters of fluid in the first 24 hours, some of that extra fluid is inevitably going to end up in the alveolar interstitial space, severely impairing oxygenation.
Okay, the biology makes sense. However, we have to look at this critically. As robust as that physiological logic is, I have to ask, how much of that massive difference, 5% versus 0.6%, is actually an artifact of the trial design itself?
That's a brilliant question. We must strongly contextualize this pulmonary edema finding by noting a major, unavoidable structural limitation of the trial: open-label ascertainment bias.
Right.
Because this was an open-label trial, there were no placebos.
Yeah.
The treating clinician standing at the bedside knew exactly which group the patient was assigned to. They knew if the patient was in the high fluids group because they were the ones hanging the bags.
All right, so let's role play this out. Imagine I'm the unblinded resident covering the ICU overnight.
Okay.
I know my patient is in the liberal fluids arm. I know they got over 2 liters of fluid today. They start breathing a little faster, their oxygen drops slightly, and I order a chest x-ray. I look at the x-ray, I see some hazy infiltrates. Because I know they got a ton of fluid, my brain immediately jumps to, that's pulmonary edema from the trial fluids. I document it in the chart, and it becomes a trial statistic. But if I'm covering a patient in the restricted arm and they have the exact same minor oxygen drop and the same hazy x-ray, my brain might say, well, they barely got any fluids. This must just be acute respiratory distress syndrome, ARDS, from the underlying sepsis inflammation. Same patient, same symptoms, completely different diagnosis because of my inherent bias.
Exactly. A clinician acutely aware of the trial arm might be much more prone to diagnose, treat with diuretics, and report that event as pulmonary edema in the fluid group than they would be in the restricted arm.
Makes total sense.
So while the underlying physiological mechanism for increased pulmonary edema with more fluid administration is incredibly sound, the exact magnitude of that difference, the 5% versus 0.6%, might be significantly exaggerated by the unblinded nature of the clinical reporting.
It's a real physiological signal, undoubtedly, but we have to view the exact numbers printed in the table through the cautious lens of potential reporting bias.
Exactly. It's a signal we should respect, but not necessarily a pure, unvarnished truth of the magnitude.
Now, how does ARISE fluids sit alongside other recent major trials in sepsis resuscitation? We cannot view this trial in an academic vacuum. Sepsis research has been moving at light speed over the last few years.
We absolutely cannot view it in isolation. We have to briefly but meaningfully compare ARISE fluids with the CLOVERS trial, which was published recently and tackled a very similar core question in the United States.
I remember CLOVERS.
The CLOVERS trial also tested a restrictive fluid and early vasopressor strategy against a liberal fluid strategy in patients with sepsis-induced hypertension. And the overarching conclusion of CLOVERS was remarkably reassuringly similar to ARISE fluids.
Which was?
They also found no clear improvement in major patient-centered outcomes, including 90-day mortality, with a restricted fluid strategy.
But there are key, highly nuanced distinctions between the two patient populations they studied that make ARISE fluids a unique, critical, and highly valuable addition to the literature, rather than just a repeat.
The most critical distinction is the timing and the defined severity of the shock. ARISE fluids enrolled patients significantly earlier in their resuscitation course.
Right.
They specifically captured patients before they had received that heavily debated guideline-mandated 30 milliliters per kilogram of fluid. CLOVERS had a slightly different fluid run-in allowance.
Okay, that's a big difference.
ARISE fluids also strictly required confirmed, persistent hypotension, specifically despite at least 1 liter of fluid, and they mandated a confirmed blood lactate level above 2 millimoles per liter.
Right.
This strict entry gate ensured they were studying a distinctly severe, very well-defined phenotype of early septic shock, right at the exact moment the crucial fluid versus pressor decision is most pressing for the doctor.
So what does this all mean? Synthesizing all of this, what does this mean for the clinician standing in the resuscitation bay tonight at 2 a.m.? We have 2 massive, internationally conducted, well-designed trials showing unequivocally neutral primary outcomes. How do we synthesize this clinical takeaway without throwing our hands up in frustration?
The most important takeaway from all this data is to actively, consciously avoid binary conclusions. We cannot walk away from this deep dive and declare that fluids are better or that pressors are better.
No, we definitely can't do that.
The data simply does not support rigid dogma in either direction anymore. What the data does support, incredibly strongly, is nuanced, thoughtful, individualized clinical application based on the patient's real-time physiology.
Let's break down how that actually looks. First, early vasopressors are entirely feasible.
Yep.
The trial powerfully demonstrates that initiating peripheral vasopressors in the emergency department within the first hour or 2 is safe and operationally possible. It does not cause an epidemic of limb ischemia or kidney failure, and it logically may reduce the incidence of fluid overload and pulmonary edema.
Right.
However, the caveat is that it does not magically increase the number of days a patient is alive and out of the hospital. It's a safe tool, not a miracle cure.
Conversely, we have to remember that fluids remain highly appropriate and life-saving when a patient has likely true hypovolemia. If a patient has been vomiting for 3 days, has had profound severe diarrhea, and presents you with septic shock, they have an absolute massive fluid deficit. They're dry. Fluids are undeniably the correct answer there.
Yeah.
Or if you use dynamic bedside tools like point-of-care echocardiography or passive leg raises to prove definitively that the patient's heart is highly fluid responsive, then giving fluid is physiologically sound and necessary.
But vasopressors are clearly the appropriate choice when profound hypotension persists after that initial sensible volume resuscitation, and the clinician judges that pouring more fluid in is unlikely to help increase stroke volume, or worse, might actually cause congestive harm.
Exactly.
If you put the bedside ultrasound probe on a patient's abdomen and look at the inferior vena cava, and it's plump and non-collapsing, and you look at their heart and see a hyperdynamic left ventricle that's already full, pouring another 2 liters of crystalloid into that system is highly likely to result in that pulmonary edema we saw in the data without doing anything to improve vital organ perfusion.
Well said.
The overarching lesson is that ARISE Fluids reinforces careful, continuous reassessment over blind, reflexive actions.
It forces us to stop blindly treating the printed protocol and start treating the actual patient in the bed.
Exactly.
It validates the thoughtful clinician who decides to start a norepinephrine infusion early because the patient's physical exam suggests venous congestion, and equally, it validates the clinician who confidently hangs a 2nd or 3rd liter of fluid because the patient's history and ultrasound show they remain profoundly volume depleted.
Before we wrap this up, we have to look closely at the blind spots of the data. Every trial, no matter how massively funded or meticulously designed, has limitations, and understanding those limitations is a key to applying the evidence responsibly to our patients.
We've already touched heavily on the open-label design. We have to acknowledge that true double-blind masking is practically impossible when comparing intermittent intravenous fluid boluses to a continuous titratable vasopressor infusion pump.
Yeah, that's just logistics.
You cannot effectively or safely create a convincing placebo system for that in a chaotic, busy emergency department without compromising patient safety. We discussed how this lack of blinding might logically lead to ascertainment bias regarding subjective safety events like reading an X-ray for pulmonary edema.
Another structural limitation that I think we need to highlight is the duration of the intervention itself. The strictly protocolized intervention, the actual algorithm guiding the doctors on exactly when they were allowed to give a fluid bolus and exactly when to turn up the pressors, only lasted for the first 24 hours.
This raises an important question about the nature of critical illness. The primary outcome was measured way out at 90 days. Sepsis is an incredibly complex, multiphasic, cascading illness. The rapid interventions in the first 24 hours are obviously critical for stabilizing the initial crash, but the subsequent highly variable care over the next 2 weeks, how aggressively the patient is diuresed with Lasix in the intensive care unit to get that initial fluid off, when exactly they are extubated from the ventilator, how quickly physical therapy mobilizes them, the discharge decisions made by ward physicians.
So many variables.
Exactly. None of that vast landscape of care was controlled by the trial protocol. The trialists correctly noted that these downstream decisions generally occurred under the care of ICU and ward clinicians who were unaware of the original ED treatment assignment, which helps mitigate bias. But it highlights just how difficult it is for a targeted 24-hour intervention to definitively, singularly alter a 90-day trajectory in such an overwhelmingly complex disease state.
And finally, the exclusion criteria naturally limit the generalizability to the absolute broader population of the hospital.
Yes, very true.
If a patient had pre-existing severe conditions where fluid restriction was obviously mandated, like known severe congestive heart failure with an ejection fraction of 10%, they were excluded.
Right.
If they had pre-existing treatment limitations, they were excluded. If they arrived at the ED having already received over 2,000 milliliters of fluid from an aggressive paramedic crew, they were excluded. So we have to remember, these results apply specifically to that very early, undifferentiated, but demonstrably severe shock window.
Right.
They don't necessarily apply to the complex patient who has been languishing on a medical ward for 3 days, slowly accumulating liters of fluid before finally crashing and being transferred to the ICU.
Exactly. The findings are incredibly robust, reliable, and practice-changing for the specific early population they studied. But we must be very careful as clinicians not to lazily extrapolate them to entirely different patient phenotypes who fall outside those specific clinical parameters.
Let's bring this all together for a final comprehensive summary for the listener.
Sounds good.
In adult patients presenting to the emergency department with early septic shock who remain persistently hypotensive and hyperlactemic after initial fluid resuscitation, A clinical strategy of restricted fluids combined with early vasopressors did not increase the number of days alive and out of the hospital at 90 days, compared with a traditional strategy of more liberal fluids and later vasopressors.
But the nuance is key. Early vasopressors remain a highly reasonable, safe, and operationally feasible option, and they're especially attractive when fluid overload or baseline cardiac dysfunction is a primary clinical concern for the patient.
Right.
However, the overarching, enduring legacy of the ARISE fluids trial is that it strongly reinforces the vital importance of continuous, careful, physiological bedside reassessment.
That's the real takeaway.
It warns us loudly against practicing reflexive algorithmic medicine, whether that is the old reflex to mindlessly order liters of fluid to satisfy a metric, or a new reflex to immediately initiate pressors without taking the time to carefully consider the patient's true individual volume status.
Which leaves us with a final provocative thought to chew on. We just spent this entire deep dive dissecting how two massive, distinct, rigorously executed resuscitation strategies that altered the very fluid balance of the human body, ultimately resulted in the exact same median number of days alive and out of the hospital.
It's kind of wild to think about.
Since large-scale, impeccably run trials consistently show neutral outcomes between these two distinct population-level strategies, perhaps the future of sepsis resuscitation isn't about running another 10,000-person trial to find the superior, magical, universal protocol that perfectly applies to everyone.
I completely agree.
Perhaps the future is actually about abandoning the idea of a universal protocol entirely. Perhaps the real frontier is focusing our energy on developing the non-invasive bedside tools like advanced point-of-care echocardiography, real-time microcirculation monitors that look at the capillaries under the tongue, or AI-driven hemodynamic predictive models that can instantly and perfectly identify which of the two distinct strategies the specific, unique patient lying in front of you desperately needs at hour zero. Thank you for joining us as we explored the evidence, and remember to keep critically evaluating your bedside habits. We'll see you next time on PRISM Rounds.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.
Clock's ticking down in the ER haze. Another septic case from these West Slope days. Check the pressure, run the lactate test, put this ARISE fluids trial to rest. Got two paths to walk, a heavy choice to make. How much fluid to give for this man's sake? To bolus hard or let the vasopressors climb. Praying I'm on the right side of the line. Cause the data's a coin toss. 50-50 split, still gotta make the call and live with it.